Good morning. Welcome and thank you for joining us for our Northern Light Health, Good Health is Good Business Zoom conference. We will start off today with an update on healthcare issues in the news. We'll then focus on men's health. We hope to further promote June as Men's Health Awareness Month and arm you with useful information to help encourage men to optimize their health. While there's so much we could cover, we have chosen items that can help you make a positive difference in someone's life. Our panelists today are Dr. Robert McFadgen, a family physician at the Northern Light A.R. Gould Primary Care Practice in Presque Isle. Dr. McFadgen's responsibilities include teaching medical students. Dr. Jim Jarvis, Senior Physician Executive at Northern Light Health, serving as Director of Clinical Education at Northern Light Eastern Maine Medical Center. Dr. Jarvis's experience includes serving as Program Director training family practice resident physicians. And then myself as a panelist. I'm Dr. Ed Gilkey, Senior Physician Executive at Northern Light Beacon Health. I'm a family physician with experience training family practice resident physicians as a Program Director as well. I'll also be your moderator for the next hour. Before we get started, I will read our legal disclosure. The coronavirus pandemic is an ongoing, continuously evolving situation. Northern Light Health encourages everyone to follow federal and state governmental guidance and mandates. The information presented in this session is provided for educational purposes only and is not meant to substitute professional or medical judgment. Northern Light Health does not know the particulars of your situation, so the information presented today is intended to be general in nature and may not apply to every individual situation. Northern Light Health and the presenters make no guarantees or warranties regarding any information provided. A reminder, this hour is for you. If at any time you have a question for our panelists, please use the Q&A function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following this hour to answer our quick 5-question survey. Your input directly affects our topics and helps guide our future conferences. Dr. Jarvis will start us off with the latest on healthcare in the news. Dr. Jarvis?
Well, thank you, Ed. Next slide, please. So just a brief update on where we are with the COVID-19 pandemic. Wonderful news is that case counts and hospitalizations across the state of Maine remain very low. That is remarkable. We have really seen a major turn in where we are in terms of this pandemic and what its reach is. But there are definitely still circulating variants in Maine and across the United States, so we do need to remain vigilant. There are still people who are becoming sick and extremely sick due to the virus that causes COVID-19. I want to remind people that a second bivalent messenger RNA booster has been authorized for individuals who are over age 65 or have an underlying immunocompromising condition. And those that fit in that category, I recommend that they reach out to their primary care provider and have a discussion as to whether it's appropriate for them to receive that vaccine now. I will say that right now there is no word on global vaccination for the fall or the winter, though we do expect that there will be a recommendation for another booster shot during that time frame. And many of us feel that this will become an annual or seasonal vaccine, much like we've seen with influenza. One of the concerns that we have right now is with the end of the public health emergency, there are many individuals who are starting to be removed from Medicaid, which in the state of Maine is called Maine Care. And that's a concern and should be a concern for those of you who have employees who may not have insurance based upon their employment, but actually are reliant on Medicaid for their health care, that they may need to re-enroll or they may no longer be eligible due to the end of the public health emergency. Next slide, please. So there are some other health concerns. There are still plenty of other respiratory viruses out there, which makes it very confusing for people. So I still recommend that people who have upper respiratory symptoms like cold-like symptoms, sore throat, runny nose, things like that, that they do still test to make sure they don't have COVID-19. There's also been an increase in the state of Maine and across the country in cases of GI bugs. So people are coming down with diarrheal illnesses and vomiting and things like that. And so remember, it is very, very important for us to continue to wash our hands, cover our mouth and nose when coughing and sneezing, and stay home when we're not well. Please continue to support that in your employees, your students, your workers, and your patrons, because it's really, really important that we stay healthy. If one of the lessons that we learned through the pandemic is we can make a huge difference when we all participate in keeping each other healthy. There are a couple other health concerns out there that are kind of seasonal for us. So certainly the tick population in the state of Maine continues to increase. So we know there are many more tick-borne illnesses. So please take precautions if you're out in the woods or high grass or anything like that. And then there's actually a recommendation that came out just yesterday, or a concern that just came out yesterday, that we are seeing an increase in the amount of rabies out in wild animals. So if you do come across a wild animal or a domesticated animal who just appears as they're not acting well, please reach out to animal control or something along those lines, but do not go near any animal that's acting in a weird behavior, because we do have a higher rate of rabies than we typically see this time of the year. Next slide, please. And I think we'll now turn it back over to Ed, unless Ed has some questions for me.
Well, I do have a couple of questions for you, Jim, but our audience is welcome to ask questions at any time, and we'll certainly open up the floor at the end of our presentations today for further questions on health concerns that Dr. Jarvis is talking about. But Eastern Maine Medical Center had 0 COVID patients in the hospital this week for the first time since the first admission back in 2020. What is the significance of this?
Well, one, it's just, again, it says the tremendous work that's been done across the state of Maine in order to keep our citizens healthy. And it says that we've done a very good job. It also says that the amount of circulating virus is certainly much lower than it's been in the past, and that's good news. But we also have to take that with a little bit of grain of salt. If you remember, for most of the pandemic, once we had testing available to us, we were testing everybody that was admitted to the hospital for COVID-19, meaning that not only were we picking up people who were symptomatic, but we were also picking up that large number of people who were asymptomatic, who may have been coming into the hospital for other reasons. Now we've gone back to just really testing people who are symptomatic. And so there may still be some people that do have the COVID-19 virus, but right now are not showing any symptoms of that. But overall, it is wonderful news for us, and we should all be celebrating the fact that we have really turned a tremendous corner, and we want to keep it that way. It's also important to remember that this is also during the time when we have opened up some of the restrictions that we had on visitation, and we no longer require masking, but have a masking optional policy, and yet we're still seeing very, very low numbers. Again, encouraging news for both healthcare workers and the community at large.
I wanted to also grab your opinion on tick-borne disease. So I think most of us think about what to worry about with ticks is getting Lyme disease. And we also know, if discovered early, Lyme disease is a treatable disease. But there's other things that these ticks carry. And because of the rather warmer winters, it sounds like the disease burden increases year to year. So when you talk about some more oddball ones like Powassa virus, is there any treatments for those? And I'm going down the pathway of, make sure you're tick aware.
Yeah, and so for many of these diseases, there are treatments for them, especially if they're caught early enough. And so a good thing to do is really preventative medicine is the best medicine. So if you have been going through the woods or walking through tall grasses, when you come home, please make sure that you do a tick check. And most of us can't turn our heads completely around to see our back, and so make sure that you have a loved one or a close friend who is willing to check that out for you, or a really good mirror so you can do that. But also, some of the other good precautions that we've talked about, wearing insect repellent is a good idea. As well as making sure that you're wearing clothing that's protective. So if you know you're gonna be doing those hiking, wear long pants, tuck your pants into your socks. If you wear light colored clothing, it's easier to spot ticks on them. If you have pets, remember, pets often bring ticks into your house, and so you need to be aware of that as well. And then if you just start to have any unusual symptoms, particularly if you start having fevers, chills without any explained rationale for it, like you had a cold or something along those lines, you may want to get checked out to make sure that that's not a concern, particularly if you're at high risk for encountering ticks.
Yeah, so I just end up this part of the session by pointing out that we are somewhat bombarded on the newscasts with tick information, which is really great, public service announcements as well. I will say for the last 2 weeks at Northern Light Health internally, we're educating one another for our entire staff to really be quite tick aware. So just to drive home the point that prevention really is the best course of action here. Well, thanks, Jim. We'll look forward to you presenting another section a little bit later.
Thanks, Ed.
Our next speaker is Dr. Rob McFadgen, who will speak about prostate health, testicular cancer, and erectile dysfunction. Rob?
Thank you, Ed, and thank you everyone for having me here today. As Ed mentioned, I have a few things that we're going to discuss today. First, I'm going to focus on the prostate gland. Many people have heard of it. I will have a lot of patients, they know that there's a prostate and that their father may have had prostate issues, but what really is the prostate? I think that's first and foremost. So the prostate is a small walnut-sized organ that sits just beneath your bladder, and it encircles the urethra, which is the tube or hose where urine flows from the bladder and then out through the penis. The prostate has basically one main job, which is it makes fluid that when mixed with the semen produced by the testicles the sperm from the testicles will make up semen that is then ejaculated. The prostate gland is also involved with testosterone in a very complicated chemical pathway, but that is its main function. There's several issues that can occur with the prostate gland. Two main ones that we're going to focus on today is enlargement of the prostate gland called benign prostatic hypertrophy, which I'll most likely call BPH moving forward, as well as prostate cancer, which is of course the more concerning issue. So we'll first start with benign prostatic hypertrophy, or BPH. So BPH is a condition where the prostate enlarges in size, but not cancerous. It is just larger. So it's no longer a walnut size. What can happen is, if you remember me mentioning, the prostate encircles the urethra. As it grows, it can then kink that hose, basically, leading to symptoms with urination. It's a very common condition. The prevalence increases with age, with up to 70% of men being affected between the ages of 60 and 90. Genetics plays a role, but there are other potential causes for an enlarged prostate. It used to be thought that higher testosterone levels or testosterone supplements can cause this, but this has not been proven. Some things that do increase your risk include obesity, diabetes, or high insulin levels, and lack of physical activity, among others. Citrus beverages can decrease the risk of an enlarged prostate. I want to keep this in mind because in a future slide, we're going to talk about citrus beverages again. So the exact cause of the growth is really unknown. It's likely there's multiple things that can occur that cause the prostate to enlarge. One thing that is strongly implicated is as we age, naturally our testosterone is converted to a more estrogen-like hormone. And it is thought that this process is very much implicated in the enlargement of the prostate. So much so that one of the medications used for this will help to sort of reverse that process and can shrink the prostate. Another common cause would be chronic inflammation. So what I mean is more systemic inflammation. So things like rheumatoid arthritis. When the body has a lot of inflammation throughout it, it may lead the prostate to be inflamed and grow over time. So the enlargement, like I mentioned, will squeeze that urethra and can cause symptoms of urinary obstruction. What can then happen is, if you think of a hose again, you kink it, the pressure will build up behind that kink. So the pressure builds up in one's bladder. That makes the bladder muscles very irritated. And then that can make the urge to urinate more frequent, and then, of course, more frustrating as it affects your daily life. The thing with an enlarged prostate is there's no correlation between how large your prostate is and how much symptoms you'll have. So some patients can be completely asymptomatic with a very large prostate. The next individual could have a lot of symptoms and a very small prostate. If you have no symptoms of an enlarged prostate, we do not treat it, and we therefore do not screen for an enlarged prostate. It is only treated based off of symptoms. So what are those symptoms? So the most common symptoms of an enlarged prostate is all about the urination. So you'll have increased urinary frequency. The bladder is not fully emptied, and it's also irritable, so you feel the urge to urinate all the time. In keeping with that, the same patients will have overnight urination, known as nocturia. And this is very problematic for most patients as far as their quality of life. If they're up every hour at night, they're not feeling rested in the morning. Your urine stream can be decreased in its strength, so a softer urine stream. Patients can have issues with stopping and starting their urine, so it kind of sputters. The urine stream can actually split like a fork in the road. And then patients will often discuss having a difficult time starting the urine stream. In other words, they stand above the toilet for several minutes before anything comes out, or having to strain and push. And then on the other end of things, the urine does not stop as easily, or post-void dribbling, it's called. In time, as the prostate puts pressure and causes obstruction, it can lead to stones in the bladder, chronic pain in the pelvis, increased risk for men having a urinary tract infection, which is usually more common in the female population. It can weaken the wall of the bladder because of the pressure, and more concerning, cause what's called acute urinary retention, where you're unable to get urine to come out, and that could be an emergency. Those would be the more complications. So how do we know what the prostate does? We know that it can get enlarged, and we now discuss the symptoms of the enlarged prostate. So how do we treat this? First and foremost, lifestyle changes are always the safest. Similar to what Dr. Jarvis mentioned, preventative medicine is the best. Lifestyle changes is the best. It's the safest. Anything that we can prescribe can have side effects. So things that patients can do to avoid the symptoms, basically. The size is already there. We're talking about avoiding the symptoms. So avoiding things that irritate your bladder, especially at night. So caffeine, alcohol, spicy foods, chocolate, and citrus drinks. So I mentioned before, citrus drinks or foods can decrease your risk of having a large prostate. But once the prostate is enlarged, that same citrus will irritate your bladder, not the prostate, but the bladder, and make you have the urge to urinate more frequently. Avoiding constipation. So if anyone remembers the picture at the very start, the rectum is right behind the prostate. If you are constipated chronically or having to strain, that's going to put more pressure on the prostate and therefore more kinking of the hose and causing the urinary obstruction. Avoiding drinking a lot of fluid in the evening to avoid getting up all night. Typically, I would tell patients 3 hours before bed should really limit fluids as much as possible, maybe a sip of water before bed, or to take any evening medications. A lot of men will have scheduled bathroom breaks or have a voiding diary, so they can sort of know, how often do I go to the bathroom? Therefore, you can plan your life around that rather than enduring the frustration of having to start and stop your daily activities. Another option would be, because some men will have to go back to the bathroom very shortly after first going. So just scheduling that, knowing that in 5 minutes, I have to go back to the bathroom before I carry on with my outdoor activities and have to come in, especially in the winter in Maine, where you take off all of your boots and snow gear. There are also more natural or herbal medications, the most common being saw palmetto. Is deemed to be quite safe, but there's inconclusive evidence on the true effectiveness of this supplement. There are also medications that we can use. I'll briefly touch on them, but the two main types of medications are: one will relax the prostate tissue, allowing the urine to flow easier. The other type of medications are shown to decrease the size of the prostate, allowing urine to flow more easier. They both come with their pros and cons, and a discussion with your provider is always best on what is the best option for you. If medications do not work or are not tolerated, there are surgical options to help with the urinary symptoms, and that would be discussed with a urologist or a specialist in the field. So, other things to worry about. So there's the complications and the symptoms, but when should one really be worried? So the red flags, we call them. So noticing blood in your urine, having significant symptoms under the age of 45 years old. If a rectal exam is performed, which does not have to be done routinely, but if it is, noticing any nodules or asymmetry of the prostate gland on the rectal exam will be cause for concern. Urination becomes painful, or incontinence of urine, because typically the enlarged prostate is causing the opposite issue. So incontinence would be a concern. And then, like I mentioned, the complication of acute urinary retention could be an emergency. So since we talked about the potential red flags, it's a nice segue into the next topic of prostate cancer. So I'll muddy the waters nicely here. So having an enlarged prostate is not associated with an increased risk for prostate cancer, but men who have an enlarged prostate can still get prostate cancer and vice versa. You cannot have an enlarged prostate and have prostate cancer. And unfortunately, some of the symptoms have a high overlap. So even though there's no risk of having prostate cancer just because your prostate is enlarged, but you still could develop prostate cancer. I hope that's as clear as mud. So two differences here is that the benign enlarged prostate grows from the inside. So the inside of the gland, it grows and it squeezes on that urethra. Most prostate cancers grow from the outside of the gland, so they are not causing that same urinary obstruction, but they can. Prostate cancer is one of the most common cancers worldwide. Up to 11% of men will be diagnosed at some point in their life, and that's about 1 in 9 men in the United States. So just like the enlarged prostate, what are some risk factors for having prostate cancer? Very similar to the enlarged prostate, and that is that age is the most common or biggest risk factor. It's very rare for prostate cancer to occur before the age of 40, hence the red flag of having symptoms before age of 45. The incidence peaks between ages 65 and 74, very similar to the enlarged prostate. It's more common in the African American population. Genetics and family history play a role, especially a first degree family member, which would be a sibling, parent, or child. And one gene that has been implicated is the BRCA gene, or BRCA. More women are knowledgeable about this, as it increases risk for breast cancer and other cancers in women, and increases risk for prostate cancer in men. There are some observational links, meaning that there's no definitive correlation but between diet and prostate cancer, but diet and lifestyle are implicated in many health issues. So a diet that is very high in animal fat and dairy and low in raw vegetables has been linked to increased risk of prostate cancer. Foods such as tomatoes, soy, and coffee can decrease your risk. Again, like I mentioned, coffee can increase your symptoms of an enlarged prostate, but potentially decrease risk for prostate cancer, making everything very easy. I mentioned before with the enlarged prostate, there's no association between having high amounts of testosterone or taking testosterone supplements and prostate cancer. There is an increased risk in those who have obesity, high insulin levels, or type 2 diabetes, as well as heavy marijuana use. Alcohol and cigarettes have not been shown to be directly linked, but those results are difficult to interpret because of all of the other health issues with heavy alcohol and cigarette smoking. Interestingly, high rates of ejaculation, especially in the younger ages, so more than 21 times per month in the ages between 20s and 30s, has been associated with a decreased risk for developing prostate cancer later in life. I wanted to put that in. I figured many men would remember that one. So what can we do to screen for prostate cancer? So screening can, emphasizing can, begin at age 50 with a blood test called the PSA, which stands for prostate-specific antigen. This is a chemical that leaks out of the prostate into the bloodstream and then can be detected by blood tests. If elevated, it could indicate that there is an abnormal growth or enlargement of the prostate gland. Guidelines for screening are put out by the United States Preventative Service Task Force, or the USPSTF. Currently, there is insufficient evidence regarding universal screening, so screening everybody. And it is recommended against screening men who are asymptomatic above the age of 75. So the choice to screen for prostate cancer with this blood test should be made individually based on the patient's preference. A discussion with your provider for the full disclosure regarding the risks of false positives and false negatives is very important. So I'll often tell patients that basically this test is not that accurate, for lack of better words, but it is the best we have. So there is pros and cons, and everyone has their own opinion or preference based off of their own beliefs, and that's how it should be decided upon, as long as you're well aware of the potential adverse outcomes. What I mean by that is a false positive PSA, which is quite common, can lead to down the road invasive procedures such as biopsies, which can lead to infections, a lifelong impotence, lifelong incontinence, chronic pain in the area. So this really influences our recommendations. To make it more confusing is that if prostate cancer is caught very early without any spread, in other words, the 5-year survival is nearly 100%. But with distant spread to other organs or parts of the body, this rate drops down to nearly 30%. So it's a very slow growing cancer. It is thought that up to 70% of males who die from other causes in their 70s and above would have evidence of prostate cancer on an autopsy if it was performed. So this is why the controversy remains regarding the screening, because if so many men have it or would potentially have it on autopsy at later age, why do we stop? And then also, if there's such a change in the potential for survival with early detection, why not screen everybody? So there's things to consider, because other diseases can cause an elevated PSA or false positive, or even just lifestyle. For example, having sexual intercourse within a few days of having your blood work done could give you a falsely positive PSA. Driving a motorcycle could give you a falsely positive PSA. It has also not been shown that screening, even though early detection is key, the screening has not been shown to reduce the overall mortality in the population in any significant way. To avoid one death, 570 males would need to be screened, and of them, 18 would have cancer and 1 would survive from that screening. The overdetection of prostate cancer at an advanced age can lead to treatments that would decrease quality of life while not prolonging the life. So like I mentioned, it's a very slow growing cancer, and if a male is in their late 80s and has prostate cancer detected, now has to choose, do I undergo all the other tests and the treatment or radiation, chemotherapy, surgery, etc., and my quality of life could be very much diminished, where it would not have been the cause of my death in the first place. So what are the symptoms of prostate cancer? Very often it is asymptomatic, especially if it's localized, because it grows on the outside of the prostate and does not cause those urinary issues. But it can grow large enough, or it could grow in a different area, and it can cause the similar symptoms of BPH, the urinary obstruction. But often you'll have some other red flags. So blood in the urine, night sweats, so soaking the pillow in sheets overnight, blood in the semen, urinary retention, not able to get urine out. If the cancer has already spread, the most common place that it goes to is the bones first. So a common or a concerning symptom would be new bone pain. So it would be sore to touch that area. So tenderness in the bones without any known cause or previous issues with that. That mixed with some of the other symptoms would be cause for concern. So as far as prostate cancer treatment, that would be really discussed with a urologist and an oncologist. Often in primary care, we will discuss it as well as far as risks and benefits and looking at the patient's entire health profile, if they're healthy enough to undergo this treatment. Some patients will have what's called watchful waiting or surveillance, where they're just monitored every so many months by a specialist. So they may not need treatment right away. Overall, though, there are multiple options which can be discussed with a urologist and a cancer specialist. So I'll briefly talk about testicular cancer as well. This is a very common cancer in males between the ages of 15 and 34. It can occur outside of this range, but quite uncommon outside of that age range. Similar to prostate cancer, if diagnosed early, is over 99% curable. There is no approved screening tests for prostate cancer, testicular cancer. Unlike prostate cancer, where we have the PSA, there is no blood test or anything like that we can do. Basically, the current recommendation is for a monthly testicular self-examination. So things like feeling testicles in the shower, etc. So feeling for any kind of lumps, which can often be painless, irregularities in the size of the testicle. If there is testicular pain, anything that is of concern should be brought up to your primary care provider to discuss tests for diagnosis. Lastly, I'll talk a little bit about erectile dysfunction, a very common sexual problem in men, and they very commonly report to their doctors and also very commonly don't report to their doctors. it may affect up to 30 million men in the United States. The definition of erectile dysfunction is trouble getting or keeping an erection to have or complete sexual intercourse. Erectile problems do happen normally and progress as we age, but if it is quickly progressing, this should be more cause for concern and be evaluated and treated. There are many causes for erectile dysfunction, not just age. It can be from a problem with blood flow to the gland. It could be a problem with nerves or neuropathy. Many medications can have side effects that lead to erectile dysfunction. So again, bringing this up with your primary care provider to review your medications in detail and see what could be adjusted may be as simple as that. Emotional stress can cause erectile dysfunction. What I mean is often having one episode of erectile dysfunction can lead to subsequent episodes because of the stress of the first episode. Type 2 diabetes is a very common cause of erectile dysfunction. Smoking, another very common cause of erectile dysfunction. Heart disease or atherosclerosis or plaque in the arteries, again, because we need blood flow to the organ, can lead to erectile dysfunction. I think Ed will touch on that briefly. There are multiple treatment options for erectile dysfunction. We do advise against mail-in or getting medications from the mail without talking to your provider first. You can make sure it's safe for you to take, for one, and it is the appropriate medication, because other causes could be at play. So it always should be discussed first before trying some of the online treatment options. It's often kept quiet, like I mentioned. Many solutions exist with medications and even other interventions. So discussion is always in your best interest.
So thanks, Rob. You covered a lot of territory for us. We appreciate it, and we'll welcome you back for the Q&A portion in just a bit. Well, thank you.
Thank you.
So next, I'll speak about cardiovascular health. Let's start by looking at what is cardiovascular disease. Literally, it means diseases of the heart and blood vessels. Heart disease is typically caused by atherosclerosis, where athero means arteries and sclerosis meaning hardening, or commonly referred to as hardening of the arteries. This is caused by plaque buildup, which is caused by high cholesterol and high blood pressure. Frequently, these occur together in people. The first thing that comes to mind with heart disease is heart attack or myocardial infarction. This is typically caused by a blockage of one of the arteries feeding the heart muscle and can result in death of that part of the heart. So in this picture, we see the yellow plaque in the artery and the blood clot forming in the artery, resulting in the blockage. When we have plaque prior to the clot forming, narrowing of the artery, as seen in this angiogram picture, is called coronary artery disease. And when not enough blood feeds the heart through this artery, chest pain known as angina can occur. This is usually a warning that a heart attack can occur and shouldn't be ignored. On this next slide, heart disease can involve the valves of the heart. This picture shows the 4 valves of the heart and how they direct the forward movement of blood through the pump and prevent backflow. Valves can be damaged by many things like coronary artery disease, bacterial infections, viral infections, drugs, alcohol, birth defects, and the list goes on. Other heart diseases include arrhythmias, where the electrical activity of the heart is a problem, and congestive heart failure, where the pumping action of the heart is underperforming. I'm going to move away from the heart for a moment and mention stroke. Stroke can be caused by a blood clot or by plaque in a blood clot, like in a heart attack. In this head angiogram, you can see blockage by the loss of symmetry in the blood vessels comparing the left and right halves of the brain. Just like a heart attack, the blockage causes low oxygen or ischemia, and that part of the brain can die. Another form of stroke is called hemorrhagic, and this occurs when a weakness in the wall of the artery ruptures and allows blood to flood the brain tissue. In this CAT scan of the head, we see normal on the left, and a massive hemorrhage on the right, appearing as a black lake. On the next slide, let's talk more about heart disease in men. It is the leading cause of death in US men, accounting for 1 in 4 male deaths. If you add in strokes, we're talking more male deaths than cancer, lung disease, accidents, and diabetes combined. It's reported in the literature that 50% of men who die suddenly of coronary heart disease have no previous symptoms. We're going to look at that a bit more in a moment. Of note, as a rule of thumb, men develop heart disease 10 years earlier than women, as estrogen is very cardioprotective prior to menopause. Listed here are the main risk factors for developing heart disease. Most are probably well known to you. I'd also like to point out that these are also risk factors for stroke. Keep these in mind when Dr. Jarvis speaks about lifestyle shortly. Now on this next slide, I chose a few key takeaways for us. Thinking again about those 50% without symptoms. So 50% of men die suddenly and from heart disease and didn't have symptoms. So perhaps their unassociated symptoms include leg pain down the back of the legs with walking. This is known as claudication and may represent narrowing of the arteries feeding the leg muscles. Then, like Dr. McFadden was just speaking about, there's erectile dysfunction. Think about the related advertising for the blue pill or some other solution we see so frequently. Obviously, a large market is recognized for these products. And as Dr. McFadden pointed out, the problem is quite common. Specifically, not being able to hold an erection throughout intercourse is frequently due to an inadequate blood supply. Once again, not enough blood getting through narrowed arteries. So you can see the theme that we're developing here with the narrowing of the arteries. So you certainly can see the body gives clues about blood vessel disease in multiple ways. All these symptoms should be reviewed with a man's practitioner. I'm purposely taking us down a rabbit hole now, speaking of high cholesterol. While most people are aware of high cholesterol and treating it, there's a relatively small group of people, about 1/2%, or if you think about it this way, 1 in 200 people. So it's actually quite a bit of people, but only 1 in 200 who have familial hypercholesterolemia, or FH. There are other names for this as well, we won't get into today. These people have inherited a mutation that causes their body to not manage cholesterol correctly. Their story includes first-degree relatives who have had a heart attack or died suddenly before age 50, give or take a little. And I think we all know families that have had that. They are at increased risk of heart disease, heart attacks, and strokes. So much so that they typically do develop heart disease. So it is recommended to start checking cholesterol and other lipids or fats at age 20 for these folks with risk factors. And you all know 20-year-olds still feel invincible, so that may not be an easy task to get them to get it checked. For average risk people, age 35 is the starting point, and we all know it's not so easy to get the 35-year-old man to see the doctor. For issues with cholesterol in general, statin drugs are frequently recommended and have been shown to be very beneficial to lower the risk of the disease we have discussed today. Touching on high blood pressure only briefly today, we all know it is the silent killer. The rule of thumb is any blood pressure above 120/80 should be evaluated. Finally, I wanted to mention the use of aspirin for primary and secondary prevention of cardiovascular disease. We've gone from widespread use of the baby aspirin for these purposes to much more restricted use with individual evaluation of the risks versus benefits for each person's situation, and that's discussion with their provider. So realizing I could talk all week on this subject, I do hope the items selected are beneficial to you in helping educate others, and I will be glad to answer any questions during our Q&A session. Our next speaker is Dr. Jarvis, who will speak about diabetes, cancer screening, and healthy lifestyles. Dr. Jarvis, back to you.
Well, thank you, Ed. First slide, please. So first, I wanted to talk about an annual wellness visit, which is incredibly important for our overall health and well-being, and is often ignored by the men in our population. So first and foremost, what is an annual wellness visit? Well, it's a non-disease or complaint-oriented visit. Instead, it focuses on wellness, prevention, and well-being. The actual contents of the visit is adjusted based on your age and your certain medical conditions, because as we've talked about already, your risk factors change depending on where you are on that spectrum. The topics that are discussed may include healthy habits like stopping smoking, eating better, things like that, getting up to date on your vaccinations, any needed screening tests, particularly those that can screen for certain cancers. And then it may include future healthcare planning, including desires for life-sustaining care should you become into an incapacitated condition, or if you had an unfortunate medical illness or accident. Next slide, please. Diabetes screening is probably one of the things that will come up in most of these annual wellness visits, especially for those people who get older. Why is it important for us to talk about diabetes? Well, it is still a leading cause of health complications, including blindness and death. In fact, 13% of the US population has been diagnosed with diabetes, and 34% have been diagnosed with something called prediabetes, meaning they haven't quite met the criteria for diabetes, but they also aren't completely normal. Risk factors for developing diabetes are family history. So anybody who in your family who has had type 1 or type 2 diabetes, it certainly puts you at a greater risk. If you're overweight or obese, that puts you at risk for type 2 diabetes. Increasing age. As we get older, our bodies can't handle things as well as we could before. Our metabolism changes, and that can set you up for diabetes. Having a sedentary lifestyle, meaning that you're not very active, you're mostly just couch sitting and things like that. Or if you have an unhealthy diet, and we could talk more about that a little bit later, but basically if you're not eating enough fruits and vegetables, you're eating a lot of processed foods, and particularly foods high in fat and sugar content, that predisposes you for diabetes. And then lastly, race and ethnicity play a role. Native Americans have the highest percentage of per population of people with diabetes, followed by Asians, Hispanic, Latinos, and non-Hispanic Black persons. Next slide, please. So diabetes screening. The U.S. Preventative Health Task Force recommends that for adults aged 35 to 70 who are overweight or obese, they should be screened for prediabetes and type 2 diabetes. And if they're determined to have prediabetes, they should be offered or referred to a place where they can get effective prevention strategies in order to prevent progressing on to type 2 diabetes. Many clinicians will also recommend screening for others who have risk factors as well. So some of those other risk factors that I talked about, they may recommend getting screened regardless of what your age is or whether you're overweight or obese. The nice thing about screening for diabetes, it's predominantly done with a fasting blood sugar. So you just need to fast for 8 to 10 hours. You get a small prick in your finger and we can test your blood sugar level. Though there are some other blood tests that can also be considered depending on your own risk factors and your own medical conditions. Next slide, please. Colon cancer screening. Colon cancer is the fourth most common cancer in men. The lifetime risk for developing colon cancer in men is 1 in 23. So if you look at the number of people that are on this slide, if everybody was a male, one of them would most likely develop colon cancer during their life. So it's a very small number of people and a very important thing for us to remember. Some risk factors for developing colon cancer, like many of the things we've already talked about, increasing age is the #1 risk factor. Having had a previous colonoscopy that found certain types of polyps. Not all polyps are predisposed to becoming cancer, but some are, and therefore put you at a higher risk. If you had a family history of colon cancer or certain polyps that a member of your family have had, or if you have certain genetic disorders, that certainly puts you at a risk. Again, ethnicity and race play a factor. Native Americans, Black and Eastern European Jewish persons have a higher incidence of colon cancer than the rest of the population. Again, obesity and being overweight certainly plays a factor as well, as does sedentary lifestyle and an unhealthy diet. You're going to see this theme over and over again. People who smoke are at a much higher risk of getting colon cancer, and people who drink alcohol beyond a moderate use also have an increased risk of colon cancer. So the last few things on there are definitely modifiable and things that can change. So who should get screened? Right now, the U.S. Preventative Services Task Force recommends screening for colon cancer in all adults aged 45 to 75 years who are asymptomatic, meaning that you don't have any symptoms suggestive of colon cancer, in which case you don't get a screening test. You need to have a more diagnostic test for those individuals, but if they're asymptomatic. There's a stronger recommendation for those 50 and older. Really, it's only been the last couple of years that we've talked about screening people from age 45 to 50 who are asymptomatic. And that's because we're starting to see an increase in colon cancer in younger age groups. That may be because we have as a society, become a little bit less healthy than we've been in the past, and particularly in dietary reasons. That may be why we're seeing that in a younger age. Hence the reason of lowering the recommended age from 50 down to 45. Clinicians should selectively offer screening for colon cancer in adults who are aged 76 to 85 years. Evidence indicates that the net benefit from screening all persons in this age group is small. And that's because colon cancer typically spreads slowly, and therefore most people over this age would probably succumb to some other kind of illness or from old age prior to colon cancer. But in determining whether the service is appropriate in individual cases, patients and clinicians should consider the patient's overall health, prior screening history, and preferences. So it really depends on whether you were at risk before and what your life expectancy is based on your current health conditions as to whether you should continue to do screening after the age of 75. Next slide, please. So recommended intervals for colon cancer screening, because there are many different kinds of tests that can do colon cancer screening. There is a high sensitivity fecal test. Basically, we test your stool for blood and certain other things. And the high sensitivity one of those needs to be done every year. If we add to that looking at specific DNA components that are suggestive of colon cancer, that same test then can expand out to every 3 years, depending on your health risk. A CT colonography, which is basically getting a CAT scan to look and see for colon cancer. Some people think that that's a better test because they don't have to do the prep. They actually still have to do some part of a prep for that test. So it's not the end all be all against doing colonoscopies. That one needs to be done every 5 years, as does the flexible sigmoidoscopy. A flexible sigmoidoscopy may be stretched out to every 10 years if you're also including that with a FIT test every year, but that was already the recommendation. So really the gold standard is getting a colonoscopy. And the reason being is that a colonoscopy, if they see something, they can actually do a biopsy right then and there, which is very helpful. And a negative colonoscopy would require screening every 10 years. So it actually has the longest time frame in between intervals. Those who have symptoms or risk factors may need to be screened earlier and more frequently. And I really hammer that home. Just because you had a negative colonoscopy 7 years ago, if you're having issues like blood in your stool or black tarry stools, that needs to be addressed and probably requires you to get a colonoscopy rather than waiting out the full 10 years. Next slide, please. Lung cancer. So lung cancer is the second most common cause of cancer, and it's the leading cause of cancer deaths in the United States. So incredibly important for those with risk factors to consider getting screening for lung cancer. And that should say, I apologize for that, to say risks for developing lung cancer include smoking is by far the leading risk factor. In fact, 90% of cases of lung cancer are due to smoking. Increasing age also increase your risk there. The U.S. Preventive Health Task Force recommendation is that annual screening for lung cancer with low-dose CT scan is recommended in adults age 50 to 80 who have had a 20-pack year smoking history and currently smoke or have quit smoking within the past 15 years. A pack year history means that how many packs of cigarettes do you smoke per day over the year? So somebody only smokes 1 pack a day, it would take 20 years to reach that. Somebody who smokes 2 packs a day, their 20-year pack year history is actually only 10 years because they smoke 2 packs a day. And so that's really what we're looking at there. And screening should be discontinued once a person has not smoked for 15 years or has developed a health problem that substantially limits their life expectancy or ability, or if their willingness to have a curative lung surgery. So if they found a tumor and you aren't going to be able to have the surgery, then there's no need to screen for that for lung cancer at that point. But again, the hammer home here is if you had a smoking history and you smoked at least for 20 years, or you smoked multiple packs of cigarettes for less than that, you've had to have quit more than 15 years ago to not recommend lung cancer screening. I will say that recent studies have shown that less than 40% of people who are eligible for lung cancer screening, and it may even be below 30% of people who are eligible for lung cancer screening, are getting screened for lung cancer. So we're really trying to build awareness about this for people who smoke or quit smoking less than 15 years ago. Next slide, please. So really the biggest thing, and you've heard both Dr. McFadden and Dr. Gilkey talk about prevention. So when we're talking about cancer prevention, the best thing you can do is just don't use tobacco products of any kind. There are no safe tobacco products out there. and all of them have been linked to some form of cancer or another. In fact, most cancers can be linked to tobacco use and certainly raise your risk for there. Eating more fruits and vegetables and avoiding foods with a high fat content or have been processed will help decrease the rate not only of colon cancer, but also of some of the other things that we've talked about. We talked about that with prostate cancer and with heart disease as well. Limiting alcohol use, again, a major risk factor for colon cancer. Maintaining a healthy weight, obesity and being overweight unfortunately predisposes you to many other health conditions, including cancer. Remaining physically active. It seems kind of, well, how does that help prevent cancer? Well, it probably helps boost your immune system, which helps to take care of some of those mutations, and certainly just gives you a general sense of well-being and means that to be more active. It certainly helps with some of those other conditions like diabetes and heart disease. And then lastly, I put a plug in there for wearing sunscreen. You've heard us talk about the second, third, and fourth most common cancers in men. We didn't talk about the number one cancer in all individuals, and that is skin cancer. For most people, skin cancer is not something that we talk about in terms of loss of life, though certainly there are skin cancers that can do that. But skin cancer is still a major cause of disease in individuals. And so wearing sunscreen when you're outside is important to help prevent that from being a problem. And just one less thing for you to think about. And I believe that is my last slide. So I'll turn it back over to Ed.
Well, thanks, Jim. I now invite Dr. McFadgen to join Dr. Jarvis and me on video for question and answers. And Jim, this first one's for you from our audience. Are statins safe and what are the side effects? And I'll preface this by saying that we currently treat lipid problems, cholesterol included, very aggressively with statins. So, lots of people are on statins and we know it. So I think that's a really important set of questions there. So are they safe and what are their side effects?
Yeah, so certainly statins are safe. As you talked about, there are many, many people who are on them. And in fact, if you talk to some of our cardiothoracic surgeons who earlier on in their career spent most of their time doing bypass surgery, the number of bypass surgeries in the United States per capita continually and steadily decreases. Why? Because we use statins, and statins certainly help prevent progression of heart disease and in fact can actually assist in people who have heart disease. There are definitely some people who have side effects from statins, but the overwhelming majority of individuals do not have any side effects whatsoever from taking a statin, and that's good news. And again, their safety profile is fairly high. So what are some of those risks? Statins can affect the way your muscles work, and therefore can cause crampy kind of feelings in your muscles. And unfortunately, in some very rare instances, can cause some muscle disease that requires you to stop taking a statin. There's some other more rare occurrences of people have that aren't related to the statin, but other medical conditions they have that make it more difficult for them to take statins or actually not being able to take statins at all. But again, that's a very small minority of the population. For most people, statins not only are safe and effective, but also have no side effects.
Yeah, great. Great. I have another question for you, Jim, from our audience about sunscreen. So heard that 30 SPF is sufficient and you just put it on more frequently. Is that correct? So I'm going to change that question a little bit. Just talk a little bit about what SPF means.
Yeah, so SPF is the sun protection factor. And so basically what it does is, the higher the number, the more it's supposed to represent multiple layers of skin to protect us from the sun. The problem is that while companies continue to create more and more additives that can make the SPF number go higher, there's no evidence that once you get past an SPF of 30, that it actually adds any more protection than SPF 30. The key there is exactly what Gene said, which is that it needs to be applied frequently. And often what happens is, we're good, right? We put the sunscreen on as we're walking out the door, and then we're outside for hours on end. And that can't happen. As we sweat, we kind of remove that sunscreen from us. And certainly if we go out in a pool or into the ocean or some other water activity, that sunscreen comes off of us. So you do have to reapply it every few hours to make sure that you're still getting that full benefit. It does not last forever. You can't apply SPF 60 and then expect that for days later you still have protection. All of them only work for a few hours. And again, after you get past SPF 30, there's no real evidence that any of them has any added benefit for you.
Yeah, so in selecting that, that's kind of important information. If you think about how long it would take to get sunburned, which is a first-degree burn for the skin, if you figure out how long it takes you and you put something that's SPF 4, theoretically you could last about 4 times longer in the sun before it starts. So the higher the number of the SPF, theoretically the longer. And then Jim, one more thing here. Just mention how safe are these chemicals for the skin in the sunscreens?
Yeah, for the things that are marketed here in the United States, there's no evidence that for most individuals that the chemicals are harmful. There will certainly be some people that may have an allergic reaction or a skin irritation reaction to some of the chemicals. That's something that to talk over with your primary care provider or dermatologist as to what would be safer for you. For most individuals, if they had to, they could go to a zinc-based product, and there are very few individuals who have difficulty with a zinc-based product. But for most of the fact, what's out there commercially is perfectly fine and safe. And in fact, remember, skin cancer far worse than any kind of reaction you might have from the chemical itself.
Okay, well, thanks. So I'll just kind of tune the 3 of us into the idea that there's only a few minutes left, so we'll have to speak fast, even faster. So Rob, this question's for you. So a 75-year-old requests a PSA test. What's your response to that? Like, how do you talk to that patient?
Good question, because we will get that a lot. So one thing is, I never would deny anybody a testing if they wanted. I think the main thing is just a joint decision. So being aware that it is not recommended at your age range. There's a potential for higher risk of false positive in your age range because your PSA could be elevated just because of your age. And like I talked about in the slides, that it can lead to downstream issues, with testing and biopsies. That being said, as long as everyone is the patients are well aware of all these, then I think it is. I would still allow them if they wanted to. I often tell patients that I feel my job is like a buffet restaurant owner, and my job is to put out all the options for you, make sure that they're relatively safe, and then allow you to make an informed decision of how you want to fill your plate.
Mm-hmm. Yeah, I think the point of that informed decision is really important. I mean, this is not as simple as, oh, I'll just take that prostate blood test. There's ramifications because the false positives are actually significantly high. And then we have to do things like invasive biopsies and stuff to figure out how significant that finding is. So that was a point to get across. I'm going to shift gears back to Dr. Jarvis. I see you put up a link to a better diet. Could you just comment quickly on what's a healthy diet and maybe throw in a Mediterranean diet in your answer?
Yeah, so actually there are many different kinds of diets out there that are much better than the typical American diet. The website that I put there actually helps you to kind of gauge based on your own health risks what might be a good one for you. I know that everything becomes a fad at some time, but the traditional Mediterranean diet, and again that will actually have a link to where you can go and find one, is probably one of the most healthy ones that we've seen, particularly in terms of heart disease and protective effects for us. But there are many ways for us to eat more healthy, mostly cutting out processed foods, high sugary content and high fat content, and just trying to eat more fruits and vegetables. The one thing that you can hammer home is if you can eat more fruits and vegetables, it probably just overall is a better healthy diet for you.
I'll put 2 cents onto that. When I was working up in Alaska, it was interesting. From the time they discovered oil, the life of the Alaskan natives changed dramatically, went from a predominantly subsistence type of lifestyle where they're living off the land, if you will, and all the foods that come with that, to, as they jokingly called it, the Mickey D diet, which is a pretty common way of looking at the Western American diet. And within one generation, measured in between 20 and 25 years, the incidence of diabetes essentially went from 0 to about 20%. Just in 20 years' time. It goes to show you what effect the diet can have. So we've reached the end of our scheduled time. We've included resources for you at the end of this presentation. Thank you all for joining us, and thank you to our panelists for so much great information. I hope this hour helped you to expand your understanding of men's health and offered you several ideas to share with others, and please share that with others. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information. Our next session will be on July 20th. Our topic will be strategies for preventing workplace injuries. Lots of great ideas will be coming our way. I hope you will join us. We will send you the link for this session. We encourage you to share the invitation with your friends and colleagues. By working together to promote good health, we will be promoting good business. Thank you and have a good afternoon.